So welcome everyone. My name is Dr. Adamakis. I'm the Associate Program Director of the Metropolitan Harlem Emergency Medicine Residency. As well, I am the Chair of Fundraising for the Gender Equity Medicine Research Foundation, and which is part of FemInM, and I'm also one of the All NYC faculty members, and I will be hosting this conference today. So a couple housekeeping points before we get started. Everyone, please make sure your microphones are on mute. Please have your names up. You could also include your institutions. So Bo Guan, you are not muted. I'll fix that. You can put your names, your institutions. It's nice to know where people are coming from. Make sure you're muted, and we hope you enjoy this conference. You are going to see a QR code on your screen. That's for us to take attendance and for registration. Please just scan it with your phone. If you have an iPhone, you can use a camera and it will capture and go directly to the link. Or if you don't have an iPhone, you can use a QR phone application reader. So without further ado, let's get started. Welcome. Make sure you use the QR code and register. Also, we're going to be on share screen mode most of the time. One of the best things would be if maybe half of your screen, you can see the slides, and then the other half of the screen, you actually see the videos, because we're going to have different lecturers come up, different panel members come up. So it'd be nice if you get to see everyone who's going to be talking. So as I said, I'm the Associate Program Director of the used to be Metropolitan Hospital Emergency Medicine Residency. We've recently joined with Harlem, and we're now called the Met Harlem Residency. As well as taking care of your usual types of patients that we normally see, we're also getting our residents exposed to a lot more trauma. We have a very rigorous didactic curriculum. We also have our residents presenting at national conferences, lectures, research. I feel like a really proud mom, and I'm really happy to be here representing my hospital and representing All NYC EM. So welcome. So a couple of announcements before we get started with our keynote lecturer that everyone's been waiting for. Please register. It's very important for us to keep track of how many people are involved. And a big announcement is that we are opening our All NYC fellowship applications. So this is mostly residents who attend this conference. For all of the residents who attend, if you are going to be a senior resident next year, so a PGY 3 in a 3-year residency, or a PGY 4 in a 4-year residency, and you're interested in a career in academics and you want some sort of mentorship and some sort of training, this fellowship is great for you. What you're going to get, it's a 1-year-long fellowship. You're going to learn about conference development. You're going to get mentored by some of the best presenters with presentation skills. You're going to help us build a medical student boot camp. We have a chief resident retreat that you're going to be part of. There's tons of networking opportunities, especially if you want to stay in New York. It's a really great opportunity. You're going to be surrounded by great people. There is different sorts of regional mentorship opportunities we offer you, and we cover your costs. This year, CORD is going to be virtually, but you will be attending CORD via us. So it's actually pretty competitive, the application. I suggest you guys start looking at the application, and the deadline is December 1st. You can find all of this on our website for more information. This is our agenda for today. We're going to finish with my welcome. We're going to move on to our keynote lecturer. And then the way this conference is going to go is we have different blocks of lectures. So we tried to pick controversial topics in evidence-based medicine. We're going to hear different sides of the story, different lecturers giving their points of view, and then we're going to have a panel discussion after every short lecture. Each lecture is about 10 minutes. So hopefully you enjoy this different style. We figure something different is always something good. All right, without further ado, I would like to introduce Dr. Scott. She is a graduate of LSU and completed her residency at Boston Medical Center. She subsequently served as the chief of service at Rutgers and MJS. She was the chair at Lincoln Medical Center, and she's now the chair of the Department of Emergency Medicine at Brookdale University Hospital. Welcome, Dr. Scott, and we are excited to hear your lecture.
All right. Thank you. I'm excited to be here.
It's nice to see you.
Okay. All right. Whoops. All right, very good. Good morning, everyone. It's a super cool to be here with you. Particularly, I feel honored to be able to be before so many emergency physicians who worked extremely hard over the past and continue to work extremely hard to manage this pandemic as best we can. I think it's very apropos that we're having this conversation about evidence-based medicine, given what we've been through and how we've really had to rely on each other and really scramble to get the best available evidence to guide our clinical practice over the past few months. So I want to start with, second. I want to start with just a kind of a brief, very brief discussion about what is evidence-based medicine to just kind of set the frame for our conversations today. So you want to just think about it as taking the best available evidence, which we'll talk a little bit more about, your clinical judgment, and then really I think what we oftentimes forget is that third piece, which is making sure that we include the patient's value, right? The patient's values and preference. So it's not just about the evidence and it's not just about your opinion, but it's also taking that patient's perspective and the patient's values into consideration when we're making clinical decisions. Now, the whole concept of evidence-based medicine actually started in about 1850. And I think another interesting, very interesting concept about having an evidence-based practice is that it's not a one, you don't take one course and you're done. It's actually a commitment over the course of your entire career to being an evidence-based practitioner, which means that you need to identify how are you going to digest the literature, digest the evidence, and this day and time, there are many, many, many ways, including attending conferences like today. There are blogs, other social media outlets, journals, etc. But if you think about it, if you go back to, 1850, 1900, it was a lot more challenging for clinicians to actually access the best available evidence. So you want to kind of figure out for yourself, how am I going to, on a weekly basis, make sure that I'm on top of the best available evidence to guide my practice. And then we must, I think it's necessary to acknowledge Dr. David Sackett. Dr. Sackett actually is from the United States. He went to medical school at the University of Illinois in Chicago. And then he actually moved to Canada. And he was the founding chair of the very first department of clinical epidemiology in Ontario, Canada. And in the early 1900s, in early 1980s, he actually started kind of what we now consider the evidence-based movement. He really got clinicians around the world, not just in the United States and Canada, but around the world, thinking about having an evidence-based practice. And he was one of the earlier physicians to create the level of evidence ratings, which we use today. Now, what is relevant scientific evidence and how do we get to that? So there's a theory or hypothesis, and we kind of go through this progression of animal model studies, small human trials, RCTs. We repeat, and then we start to have meta-analyses, and we start to have some conversations about what we think the best evidence is. One of the things that's super, super fascinating in 2020 is when you look back at 1918, the quote-unquote Spanish flu of 1918, and you look at how clinicians, doctors, and nurses during that time, when they were dealing with a deadly disease that was highly contagious, and they really had no evidence. And not only did they have no evidence, they didn't even know what disease they were dealing with for much of the pandemic. They really had not actually identified the pathogen. And so what happened was clinicians just kind of, they used their own small case series. I treated 5 patients with strychnine, and I had this improved outcome. And there was a lot of dissemination of information by word of mouth. The media, the other interesting thing too is the media really was not publicizing what was actually happening from a public health perspective because there was a war, right? And so the president And the government at that time really did not want to dampen the morale of Americans. And so there really wasn't a clear picture about what was happening with that pandemic for the average bloke in the country. And I think there are some parallels, when you look at how we hear the pandemic described in the media and how there's some discourse even about like exactly what's happening. And so we've also experienced the struggle to get to relevant scientific evidence with regards to how to manage this pandemic. And right now, I would say this month and the last month or so, we've just started to have some meta-analyses and some really good solid data to drive our clinical practice for some therapies related to treating COVID-19. And so next I'm going to go over very briefly just to kind of give you kind of a concept of some of the controversies over the years in emergency medicine. I'm going to start off with acute stroke, right? So I'm sure we all are aware that there's controversy about whether or not there's actually a benefit of good neurologic outcome when using IV TPA for the management of acute stroke. And this controversy has actually been going on for almost 20 years, believe it or not. And it's largely between the neurology camp and the emergency medicine camp. And I think, and my experience has been particularly challenging because I've been a leader in emergency medicine over the past 20 years or so, and really have been, part of my job has been to work with neurologists to put processes in place to give IV TPA for acute stroke. So it's really interesting, like having to kind of put these processes in place, but knowing that a lot of my colleagues have some doubt about whether this therapy is even beneficial or not. And the other interesting thing with this particular controversy is that you really have to take into consideration where you're practicing. Right. So if you're in an inner city and you've got, you're at an academic center and you have neurologists and neurosurgeons and intensivists making that shared decision along with the patient, of course, about whether or not to use this therapy. And then if there's a complication, you also have all of that backup and support to help you deal with the complication. Versus if you're a single coverage emergency physician in a rural area making this decision by yourself with the patient, and then if there's a complication, you're managing that complication and getting that patient shipped off to a more safer place. So where you practice matters, I think, when you're trying to figure out which side of this controversy you're on. And I think, more and more evidence is becoming available, and hopefully one day we kind of reach the end where we are confident about what's the best thing to do in all circumstances where acute stroke is concerned. A less dramatic controversy is mechanical CPR devices, right? These are some like sexy, beautiful toys that we some of us enjoy having in our emergency departments. But I think we all pretty much agree that there's really not a difference in ROSC survival, and particularly survival with good neurologic outcome, right? A patient-centered outcome would be a good neurologic outcome. However, again, if you kind of go back to that single coverage emergency physician in a low staffing model where there's maybe just a doctor and a couple of nurses and a PCT, some argue that these mechanical CPR devices, while they may not change outcome, it kind of helps the team get the job done. And there's actually, I referenced this, the Rebel versus the Skeptic from SMAC 2019. That video is entertaining, and they actually go over some of the controversies in emergency medicine in a comical and informative manner, and they actually cover this topic also. A more kind of recent-ish controversy is the non-operative management of appendicitis. And this year, I think within the past 6 months or so, we've actually had two very good articles published. One was guidelines from the World Emergency Surgery Journal. That's kind of, they published their most recent guidelines about the management of acute appendicitis. And then there's the reference I have below. And I think what it all boils down to is patient value and preference, and then identifying that right subgroup of patients that would potentially benefit from non-operative management, right? And I think what's interesting here is assuming the patient fits that subgroup where you think like, you know what, you have a non-complicated appendicitis, and I think that you would do well with non-operative management or antibiotics to treat your appendicitis. And you could have a patient that's like, you know what, doc, I really can't afford to have surgery now, be out of work, but if I plan my appendectomy, it'll just make my life a whole lot better and a whole lot more manageable. That's like kind of a circumstance where you take the best available evidence, you identify the patient who most likely will benefit from non-operative management, and you actually do shared decision making with your patient to come to a clinical decision about what's best. And then this one, I think we all kind of put this bit of evidence in the back of our brain when we're doing our resuscitations on a daily basis. But there's really not good evidence that epinephrine improves survival with good neurologic outcome, right? And so I think most of us probably know this, but when you're calling for the epi in your resuscitations, it feels like you're doing a good thing. But it's not necessarily true. The patient may survive in the ICU and drive up, their healthcare costs. But at the end of the day, there's no good neurologic outcome, and they may expire, within days or weeks after the resuscitation. So I do think this particular controversy warrants a little bit more discussion in the emergency medicine community, particularly if we want to try and reduce the cost of healthcare. Are we really doing right by the patient? Is it a really good patient-centered outcome when we are using epinephrine in the way that we most commonly do in resuscitations? And then I want to kind of, I have to touch upon COVID-19, and I know all of you are doing your best to stay on top of the most recent literature recommendations data. The subtopics that I have bolded on this slide, there's much more evidence to kind of support how we use these therapies. Now, reuse of the N95, I don't think any of us are happy about that. But there is pretty good evidence now that there are ways that you can safely reuse N95s if we get in a position where we have to do that. Thankfully, I don't feel like that's going to happen. I feel like we were definitely in trouble, and in many places N95s were not available in the spring. I think in the fall and moving forward, that's less of a concern. But it's nice that some of our colleagues have actually done the research to help support what would be a good practice should we find ourselves in that situation. And then the topics at the bottom: anticoagulation, awake proning, ECMO. I think we're all kind of on the same page where hydroxychloroquine is concerned these days. But those topics on the bottom, the evidence is still coming in, and we're still kind of trying to figure out what's the best thing to do, except hydroxychloroquine. I think we all agree that that's not helpful. This two-part podcast on the Rebel EM site was just published on October 13th. I think they're both about 30 minutes, and I have no financial disclosures to report, but I really found that Dr. Razy did an excellent job of covering all of these topics in an hour and really giving you like QR codes to get you to the actual articles and evidence that he's referencing. So if you haven't already taken a listen, I think it's worthwhile to do that to get yourself up to date on the best available evidence with regard to the management of COVID-19. And then I'll kind of end with a less controversial, kind of entertaining dilemma in emergency medicine, and that's like the use of IV fluids, and then which IV fluids do we use? So it's pretty common practice in emergency medicine that if you're drawing blood, you put in a peripheral IV. It's pretty common practice that if you're admitting a patient to the hospital, it's the expectation that that patient has a working peripheral IV. It turns out that we know that there's a pretty significant number of peripheral IVs that are actually never used, or we put them in the emergency department. We maybe give a bag of whatever IV fluid, most likely normal saline, even though the patient may not necessarily need that. and then the patient goes on to be in-house in the hospital, and nobody ever reuses that IV. So it really begs the question, should we have more stringent guidelines around when we actually place peripheral IVs? I think we all kind of feel like it's a relatively low risk procedure, and we just put those IVs in. The other thing is that emergency departments historically are stocked with normal saline, and that's our go-to IV fluid. But we do have some pretty good evidence that there are circumstances where we may be exacerbating acute kidney injury, and that we should be using balanced crystalloids. In order to do that, we have to change practice, stocking processes, purchasing processes, and also engage our nursing colleagues. We'd have to not just the emergency physicians, but nurses would also have to be on board with changing practice with regards to IV fluid choices. So this is another, the Center for Medical Education has a quick YouTube with Dr. Pescatori, which is actually pretty good and easy to listen to, and he kind of gives a brief overview of IV fluid choices. And then if you just Google IV fluids, normal saline versus balanced crystalloids, there's an awful lot of information available for you to kind of take a deeper dive into IV fluid management. And then I just want to finish up by saying that I really encourage you, and particularly over the course of this morning, right, to think about patient-centered outcomes, keeping our patients first, right? So all of the academic discussion, at the end of the day, the goal is to get to evidence-based practice, keeping our patients first, and doing the right thing by the patient. I think sometimes we really get, excited about new therapies, and perhaps at the end of the day, there's no real change in outcome from the patient. Maybe it costs more for this new fancy therapy, but we don't actually have a change in the outcome for the patient. So when you're listening to the lectures over the course of the day, ask yourself, does it change the outcome for the patient? Is this creating a better outcome for our patient? And that really should be at the forefront of our minds. So thank you so much, and thank everyone for being here, and I really look forward to hearing the rest of our lecturers.